Statement. All right, well, hello, Dr. Derouen. Thank you so much for offering this incredible opportunity for our Club Med Virtual members. My name is Mariana, and I'm the event spokesperson for Club Med Virtual. I will be leading today's session, reading any comments posted in the chat and facilitating the conversation as we go along. Before we start, I want to remind everyone to maintain proper etiquette and please keep themselves on mute unless Dr. Derouen specifies otherwise. If you have any questions, please post them in the chat and we will address them as we proceed through the session. A Google survey will be administered for Wayne State University students at the very end of the session to verify your attendance and will close 30 minutes after the session terminates. Please stay on the call for at least 5 minutes after the session is over to ensure that the survey is working for you. This session will also be posted on YouTube in case you are unable to attend or want to revisit certain topics that Dr. Derouen discusses today. But you cannot receive shadow or attendance hours if you're not present in this call and complete the survey. All right, I'm going to turn the session over to you. You can share your screen if you'd like.
Okay, thank you guys for having me. And I will say that I would hope that this is interactive and we can think through things together, especially in the differential part. So it's totally okay if you unmute. I would just ask Mariana to maybe have you guys, like, whoever goes first, like, you can filter through that so everyone wouldn't speak at one time, and of course be respectful of one another. Okay, so now I'm gonna try to share my screen. Can you guys see?
Yep.
Perfect. So I wanted, like, as we said, my name is Dr. Erkeda Derouen, and this is our shadow session. I'm really excited to be here, and I hope that we can all learn from one another today. Not just me, you're all, I'm sure you guys are keeping up to date with a lot of stuff too, especially for those of you who are studying for the MCAT. And with the pandemic going on, there's a lot of healthcare literature, I'm sure, that's out there. For today's agenda, we'll talk about a little bit about me, but not too much. I guess you can ask questions at the end if you have anything. We'll talk about a case and a differential. Then we'll do a little deeper dive into that topic and then open it up for Q&A. So a little bit about me for those who weren't checked in the beginning of the session where we were chatting. I am a DC area native living in Maryland, about 10 minutes outside of DC. I went to undergrad at Hampton University in Virginia. I attended medical school at Boston University School of Medicine. Then I came back to Maryland for my residency program at the University of Maryland's Family and Community Medicine Residency Program. And after that, I actually did the National Health Service Corps, which is something that you guys may look at into once you get to your first year of medical school, because there are 3 tiers where if you apply in your first year of medical school, they can pay all of your college tuition, all of your medical school tuition, if you agree to go into a primary care specialty. The second one is when you apply in your 4th year, which if you weren't too sure if you would go into, say you went in your first year and you were like, I don't know, I think primary care. And then when you went to your rotations, you realized you were a surgeon. That would not be a good idea because you wouldn't be able to match into surgery, or you'd have to pay them back that money. So in the 4th year, you can be decided in primary care and they'll pay a fair chunk for the next 4 years for you throughout residency. Or if you, the third option is once you have become an attending and graduated from residency, you can do a community 2-year National Health Service Corps program where they'll pay you every 2 years. So I worked at a federally qualified health center due to that for about 3 years outside of Baltimore, where I worked on transgender medicine, HIV medicine, and general primary care. And now I'm currently an associate medical director for a telemedicine company. I started there about 2.5 years ago, which is completely before telemedicine kind of blew up, thanks to the pandemic. So if you guys have questions about that at the end of the conversation, we can talk about that too. And just a little tidbit about me, like nice handbags and beaches. So those are some things that you have to continue to look for things that make you happy outside of medicine. So we'll get into the case. And then this part is where I definitely invite for us to be interactive. So feel free to raise your hand and you can unmute. And if you have an idea, we can think through it together, because this is kind of how medicine works in action, where you're presented with a scenario. And then from that scenario, you have to use all of your medical knowledge to kind of form an idea. And what my mentors in medicine would tell me is you kind of work backwards. So you think of all the possibilities, and then from there, you figure out why, you kind of cross out why it's not that, and kind of formulate a case like you were a lawyer, where, okay, this is the information I was given, and this is why it's this, and because of these points. And from there, you kind of stand by your differential and your diagnosis. So in this case, let's meet Kate. She's a 22-year-old female dental student, kind of like what we were talking about. She's probably studying for extra exams after she took her DAT, with no significant past medical history. She has had vaginal discharge for about 3 days, and her last menstrual period, that's that LMP, was on the 20th. So it was about 10 days ago. So she likely isn't pregnant. What questions would you like to ask Kate?
Has she ever experienced this before?
No, she has not.
Does she have any pain with the discharge?
No.
Possibly the color of the vaginal discharge?
Yes, that's a great question. You kind of want to know what it looks like, a description, because discharge can vary. So her discharge is a whitish yellow color. Another component you might want to think about is the consistency. Is it thick or is it thin? Hers was thick.
Any medicine that she might have taken?
No, she's not taken any medicines or supplements.
Does it have a smell to it?
No smell.
Maybe a change in diet?
No change in diet.
Is she having any urinary problems?
It does burn a little bit when she urinates.
Is she sexually active?
She is sexually active.
Did she speak with her partner or someone that she had any sexual intercourse with?
She did not talk to her partner, but I will note that she has a new partner that she began having intercourse with in the past month.
Was she being safe?
She typically was safe, but she did have unprotected sex a few times. Are there any social history questions you'd like to know about this person?
Probably just the usual, do you smoke, drink, or do any solicited drugs?
Why would that be relevant?
It's not really relevant, but I'm a scribe at an ER, and like we just ask all the patients that, so I don't know if.
Yeah, that's great. I think you're right, is a state of habit. And we ask a lot of patients that because depending on what disease process is going on, it could be relevant. But what you would think about particularly in this patient, I would ask those questions, to be honest, but I just wanted us to think through why we're asking them. So smoking may not be the biggest part of relevant thing right now. One thing you would think about with smoking is like if she was older or having irregular menstrual bleeding or something like that, you might think she might have a higher risk of cancers or something like that, like an endometrial cancer or something. In terms of the alcohol, The reason you would ask that one is because you may want to think about, if she didn't admit to having a new partner, is she having high risk behavior? Is she drinking until she blacks out, like at her dental student school parties or something like that, and having unprotected sex with people, or putting herself in interesting, unsafe environments? And then for the other component, like the substance abuse, is she using any substances that would also, like alcohol, put her at high risk? Or what does her lifestyle look like in terms of, there are a lot of people who may come in who may have an addiction and may sell themselves to and put themselves at risk, and that may not come forward. Like she may be a prostitute, or she may be those types of things. So you asked a really good question. It's just us connecting it to why we care and not just asking to ask. So I think we kind of covered a lot of things about the process going on. Is there anything else that you guys would like to ask before we move on? Okay. I think one other key point we can probably ask is there a fever? Because that may show some things about like the acuity, or how severe, or what type of infection it may be, if it were an infection. So the next slide, I know that you guys have had a few sessions. I don't know if everyone's been able to participate in one before, so I just wanted to kind of give an overview over how we're thinking in terms of differential diagnosis. So a differential diagnosis is distinguishing a particular disease or condition from others that may have similar features. So like we talked about, kind of crossing off the list and saying, this is all of the things it could be, and kind of talking through why it's not. So what types of things do you think could be going on in a 22-year-old sexually active female with 3 days of thick, purulent discharge?
A yeast infection, maybe?
Yes. So vaginal candidiasis, yeast infection.
It could be a sexually transmitted disease like trichomoniasis.
Yes. Are there any other diseases that you can think of that are sexually transmitted with discharge?
I guess chlamydia, but I know that usually has like smell with the urine.
That's on the differential. Any others?
Could be a bacterial infection, like
Like bacterial vaginosis. And then there's one we left out that sometimes I like to say that it travels in pairs sometimes with chlamydia.
Gonorrhea.
Yes, they're like sisters. Usually, gonorrhea, chlamydia and gonorrhea are so bad that there's something called super gonorrhea now, and it's not responsive to certain medications, so they're having to get different regimens up. So going through what you listed, you guys listed all of the main ones that we would think about. So yeast infections, the typical thing with that is usually not sexually transmitted, but it can occur if a woman doesn't cleanse herself well, or douches, or doesn't use the bathroom after intercourse. And typically it's a thick white discharge that is itchy in the area. And to diagnose that, you would do swabs, and you would look under the microscope, and you would see like basically fungi growing. For bacterial vaginosis, that one is usually a little thinner, clearer, like grayish white, but diseases don't read the textbook. But typically, classically, is described as that. It usually has an odor that is described as fishy. It is not a sexually transmitted infection. It's usually caused by the overgrowth of what they call bad bacteria, or if someone douches, and the other things that are associated with vaginal candidiasis. And with that one, they recommend you can have treatment with it with an antibiotic called metronidazole. And you will recommend that they try to take probiotics to grow what they call good bacteria. The other one we mentioned is trichomonas. That one is not tested as much and is very prevalent, and it is treatable. So a lot of times it's kind of like the silent infection. Then there's gonorrhea that we talked about, and chlamydia. So for our patient, we decided to take a look. Usually you should do a vaginal exam. I don't know if any of you guys have gotten the opportunity to shadow and actually be in the room while someone is doing a vaginal exam with a speculum, but this is how cervix looks. So in a normal female person born as a female, they would have a cervix. This is how you can tell that someone has not had any children yet. Typically it's a little tiny circle, and this is a cervix of someone who's had a baby. But you may see how it's kind of shiny. There's a little bit of redness, but not too much. Here it looks like a little bit of irritation, probably from natural discharge that can happen physiologically during different parts of the cycle, but it doesn't look like there's anything pathologic. Now in our patient, you see how there's more redness, or what they call erythema. It looks like she's had a baby, and there is this like purulent type discharge coming out. So this was kind of described as mucopurulent cervical discharge with cervicitis. There wasn't any odor, but there was cervical friability, so a little bit of bleeding when they did the swab. And when they did an exam, you use your digits or your fingers and you kind of feel for the adnexa, which are kind of like by the tubes. And there should be some tenderness. Now that's in the classic exam because a lot of times women are uncomfortable when you're performing the speculum exam. So with the digital exam, it's uncomfortable anyway. So it's kind of hard to decipher if it's just discomfort from the exam or if there's actual adnexal tenderness, but that's kind of a classic sign. So with our patient, after we did this, we sent off the test. Her test came back positive for chlamydia. So the CDC estimated that there were 4 million chlamydial infections in 2018. It's the most frequently reported bacterial sexually transmitted infection in the United States. And a large number of cases are not reported because, surprisingly, most people with chlamydia are asymptomatic and they don't seek testing. So it's most commonly among young people. 2/3 of new chlamydial infections occur between the ages of 15 and 24. So she's right in that age range at 22. It's estimated that 1 in 20 sexually active young women between the ages of 14 and 24 have chlamydia. Does that number surprise any of you guys?
I guess for me, no, because I already knew this, but before I knew that information, I was kind of like, oh, that's a lot.
Yeah, test them all. So how does anyone know how you treat chlamydia? And it's okay if you don't. This might be a little, I wasn't sure how much in detail to go to, but I think more is better.
It's antibiotics.
Yes. So it's an antibiotic called azithromycin. So you give that to them, they usually in a single dose, and within a week or two, their chlamydia should be gone. There's always a question as to whether or not you should do what they call a test of cure after you treat someone for chlamydia. Because if someone is diagnosed, they're always like, okay, I want to know if it's gone. But the CDC actually recommends against retesting for a test of cure unless you're pregnant. So if you're pregnant, they recommend that you test a cure within 4 weeks after treatment. How would you guys counsel her after this incident?
I think it's important to like validate the patient and make sure they don't like feel bad about themselves first, but also just like go over with them how to practice safe sex and like asking their partners for their STI panels, things like that.
Absolutely. So I always counsel our patients when they have a new partner to test together before you do anything and have conversations about using condoms. This patient, after treatment, she should not have any sex for 2 weeks, but tell her to use condoms. There's a lot of people who come back with the same infections because they don't feel like comfortable telling their partner and things like that. There are a lot of hotlines throughout the US where they can have the health department notify a partner anonymously for safety. Always also just counseling her on safe practices and whether or not how often she should test. I like to tell, a lot of times people neglect to test patients for sexually transmitted infections because they'll say, oh no, I'm in a monogamous relationship, or oh no, this and that, or I'm 65. 80-year-olds get STDs. I had a patient who was, I think 70, who came in with his wife, and I had to tell them that he had syphilis. So it's I always tell patients that when you're at higher risk, you get tested more often, so every 3 to 6 months. But even for married older people, I like to test them at least once a year, because what's the best thing that can happen? You already know your results. So it's better to test than to not know. So for this particular infection, chlamydia, there are some recommendations by our governing body, the United States Preventative Task Force, USPSTF. They recommend screening patients who are under 25 years old. And for those who are above 25 years old, they have to have certain risk factors, which pretty much encompasses everything. So a history of having an STI, like someone asked earlier, like, did she have it before? A new partner, which she had. More than one sex partner, which we honestly don't know. We don't know when her last one before him was. We just know that she had that new partner. A sex partner with other partners themselves. We don't know. Someone got it from somewhere, so they probably did. A sex partner with an STI, which she had. Inconsistent condom use. Same. Exchanging sex for money or drugs, which we kind of hit on earlier. A member of a population with an increased prevalence, their age group, or a resident in a high community prevalence. So there's also some other counseling to consider. And this part is kind of a bonus. It's kind of my passion topic, but I wanted you guys to kind of be aware of other counseling to consider. PrEP. Is anybody familiar with PrEP?
Yeah.
Yeah. Can someone tell me what it is?
It's to prevent HIV and AIDS. So if you have a partner who already has it, you can start taking that. I think it's active like a week after. So you take it like birth control.
Yep. So yeah, I always, as I said earlier, I say STIs travel in pairs. They're like sisters. So when there's one, you're probably going to find another. If you don't find it that time, if they continue to have certain behaviors, it's going to pop up. So we'll just talk a little bit about HIV in the US. There are about 37,000 new infections of HIV diagnosed each year. It's kind of broken up into different age groups. So the highest age group is at 25 to 34. And if you combine 13 to 34, that's a large percentage of our new cases. So talking to people who are young about prevention is important. The most common is Black male-to-male sexual contact. This is debatable because in our transgender population, Black trans females make up 1 in 2. 50% of Black trans females are HIV positive. So we are not sure if I see your face, Marcus. Yes, that is a shocking number to me. So we are not sure if they are breaking it down enough. Hispanic and Latino male-to-male sexual contact, white male-to-male. So we see all of the male-to-male sexual contact, and we think it's more of they should be a little more specific in terms of receptive anal sex. That is why they think it is male to male. Black women, heterosexual contact, and then it kind of goes down from there. These are the rates of HIV as of 2017 in the US. So if we look here, these are the rates per 100,000 people. So the lighter blue and the darker blue is really intense. So we can see in the South, HIV is rampant. So in Louisiana, Georgia, Florida, the numbers are very high and they're growing at a great rate. And we think some of this may be due to access to care. So, a lot of people don't have health insurance, more so in the South. And then access to sexual health education and all of these other social determinants of health that we're seeing that are kind of mimicked through COVID as well, in terms of the lack of support that patients are getting. And you see here how the lifetime risk of HIV diagnosis by SAPE is really high in the South. This talks about PrEP. So there are two forms of PrEP now. There used to be one up until 2019. So Truvada and Descovy. They're basically the same drug, except you see they both have tenofovir. There's this, the TAF versus TDF. The A part has less renal activity and is a little safer on patients who have renal problems. There are a lot of studies who have shown that prophylaxis for HIV works. I'm not going to get that deep into the studies, but if you look on the CDC, they have links to these. And there are a lot of trials that showed up, I think about over 95% of HIV is not transmittable when you're using PrEP. These are the factors that make you a great candidate. And this is for both, I know it says Truvada, but it is for Truvada and Descovy. So if you have a diagnosis of sexually transmitted infection, so like our woman earlier, Kate, if you have use of illicit drugs or alcohol dependence, like we talked about earlier, because those put you at higher risk, inconsistent or no condom use, partners who have an HIV positive status. So if your partner is HIV positive and you start on PrEP, there is a low likelihood that it would be transmitted to you. And now even with your partner is controlled and they have undetectable virus, there is now data showing that undetectable equals untransmittable. Incarceration, so because of the risk factors there, or prostitution. When you decide that someone is a great candidate for PrEP, there are some tests that you need to take in the beginning to make sure that they're a great candidate. So you want to make sure they don't have HIV. You want to make sure that their renal function is good because both medicines are filtered through the kidney. You want to make sure that they don't have Hep B. Truvada and Descovy are actually treatments for Hep B, but it can make it much worse if you stop it dramatically and things. So you want to just check their status for that. You want to make sure that they don't have other STIs, and that's just, to treat them. And you want to make sure that they're not pregnant. Women who want to get pregnant can use PrEP, but you must discuss PrEP and all of these different nuances with their obstetrical provider just to make sure that it's safe and it actually can help not give HIV to the baby. So after the initiation, so a month after, you want to just make sure that the patient is being compliant. You want to make sure, see if there is anything going on to make sure they're a great candidate. And then every 3 months, you want to at least repeat their STI test, their HIV test, and make sure that their kidney function is doing well and that they're not pregnant. When to stop PrEP? Because there's a question, like some people have different seasons in their life and they may need it at one point and they may not need it at another. So you want to stop it if they get HIV. It could be because you want to start them on more than one therapy. There's better outcomes. And Truvada and Descovy are both HIV, parts of HIV regimens, but they're not single HIV regimens. If they have a lower GFR, is the glomerular filtration rate for kidney function. If they are not being adherent to the HIV testing, because you don't want to treat them with this if they have HIV, or if they're no longer at risk, like say they decide to get married or they decide to leave their partner who is positive, or other things change in their lives. So the biggest things that I want you guys to remember is that STIs, period, are prevalent. So don't assume that any patient is low risk. Initially at face value, if you were to look at Kate, she's 22, she's in dental school, you might not have tested her if she didn't necessarily come in with the discharge and it was glaring, but ask everybody. STIs travel together, so test for more than one. Don't just, if you're swabbing her, don't just test for a yeast infection or just test for chlamydia, test for them all. And the biggest thing is HIV is preventable, so offer patients PrEP. I am a strong proponent of feeling like PrEP should be in the water. So that's all I have for you guys. So I just want to kind of open it up to discussion of anything that you guys want to ask about or you have questions about in this presentation even.
Yeah, so you guys can unmute yourselves or post the questions in the chat. I'll start off by asking, so you said that people should not get retested after their chlamydia treatment.
Mm-hmm.
Is that?
Why?
Mm-hmm.
It can link, it's kind of like a waste of resources, honestly. There isn't great, like you could retest them, they just recommend not, just because they don't want to test people every week, and it should clear within 3 to 4 weeks. The reason that they do it for you, I would recommend retesting someone like in 3 months if they still have exposure, or in 6 months. So not testing them again, but just don't test them so quickly. And some of the chlamydial cells can last in for a few weeks as well. So there may be a false positive and increased unnecessary antibiotic use.
Can I ask a quick question?
Of course.
So I know you said that we would treat the patient with azithromycin, but what's the difference between that and like doxy? Like, why would you use that instead of another one?
Yeah, so azithromycin is the first line. It's been shown to be the most effective. You would choose the second line is doxycycline, and you use that if the person had an allergy, if they were not able to tolerate azithromycin. Doxycycline has a longer course, so you would need to treat them for, I think, 7 days on that, as opposed to using the 1 day, 1 gram of azithromycin.
Thank you.
You're welcome. Any other questions? It can be about the case. It can be about medicine in general. I do do a lot of kind of sessions, so I may be a little more far removed from medical school, but I'm kind of familiar with the process. So if you have any questions about that as well.
I do have a question about, I know that you host the Prospective Doctor, so I was wondering, like, what was your motivation to host that podcast?
Sure. So for about the past 10 years, I've been doing mentorship of different organizations like the BU students or Student National Medical Association and things like that. And I found that it's really helpful. Like I had mentors in my life who had helped shape the questions that I had and things like this, these kinds of sessions and panels. So when COVID started, I was kind of looking for other opportunities to give back. And I honestly, I saw a post on Facebook on one of the doctors groups, and they were looking for a host of a podcast show. There's a physician who has hosted the Prospective Doctor for the past 3 years, and she decided to transition to something else. So I kind of took over. So I've been doing that since August. So if you guys have any questions about that, you can definitely, I'll put the link in the chat, but there are lots of topics on there about the admissions process. And then we also do a lot of interviewing people about hot topics in medicine or their specialties. So it might be worth a listen if you want to talk about like how are admissions going for med school during COVID times, or how will they change, or different things like that.
Yeah, thank you for that. So
You're
we
welcome.
have a question from Danielle. They asked, would you still test for STIs if someone has only ever had oral intercourse, and how does that change the testing method?
Okay. I particularly would, depending on what they came in for. So, say if they had only had oral intercourse, I would test. I would do what they call a pharyngeal swab, which tests their throat because you can get gonorrhea of the throat. So some signs of that is if you keep having what you feel like a strep throat or sore throats or hoarse voice, things like that, fevers, bringing up mucus, I would test, and you'd be surprised how many tests come back positive.
Would that also show up in like a blood test or no?
It would not. So you have to do a swab, and that's a good point. As a lot of testing is important in terms of the mechanism. So there are urine tests, there are swabs, and blood tests. So for urine, typically that's a screening test for something in terms of like chlamydia, gonorrhea, those types of tests that you would do. That's a screening test. And a screening is more of to see if it's there because they don't have any symptoms, but you just want to test it, make sure it's not there. So with this girl, the reason we did a vaginal swab or cervical swab was because she had symptoms. So you want to test the actual area. The reason you test the area for gonorrhea and chlamydia is because if we had only tested the urine, it's only 40% accurate. So you could miss a lot of diagnoses. And in terms of blood, the tests for blood are HIV and syphilis. Those are the more used for blood. There is a test for blood for herpes, but we do not recommend testing for herpes, honestly, unless you have lesions, and you would test that directly with a swab. The reason that you don't test for herpes directly through blood is because over 70% of people have been exposed in their life, and it's going to come up falsely positive, not falsely positive, but it'll show that there's a reaction, and you may not ever get a lesion. So it causes a lot of over testing. And the other test for the swabs that you would think about, anal swabs for people who have anal intercourse. There is a lot of anal gonorrhea and chlamydia. For patients who have a lot of intercourse and or HIV and things like that, we actually routinely do anal swabs. And then we do the pharyngeal swabs for people who are high risk. We don't test pharyngeal swabs on everyone, but if you had symptoms or if you wanted a test.
So we have a question in the chat, and one of our members asked what your hours in a typical week and day to day look like.
Okay. My schedule is a little different because I work in telemedicine and I'm doing some administrative work. So I see patients about 50% of the time online. And it's more of an urgent care schedule where it may vary from month to month. I had, before COVID started, I was also seeing patients in an urgent care where that was like a 4 to 12 hour block of time where I would see patients. And then in the other 50% of my time, I manage a team of other physicians and I help develop our electronic medical system with a team of engineers. But that's more of a non-traditional family medicine job. When I was working in a more traditional, what they call brick and mortar clinic, my schedule was kind of like 7 to 4:30 to 5, and I would see patients 5 days a week, and I would have 2 half days, so 2 4-hour blocks to kind of catch up on my notes or call back patients and things like that. That's a more traditional job, but right now I'm kind of working at a startup.
Yeah, thank you for that. So I actually saw your website and you had a quote on there about mentorship, which I really liked. And I was wondering if you could go into more detail of how mentorship has played a role into getting you where you are today.
Sure. I think mentorship is very important because there are a lot of people who have come before you who have done great things. So if you reach out to them and learn from them, I call it kind of, me and some friends call it having our personal board of directors. You don't go to everybody for everything, but there are certain people. You might have a person who is really good right now in your organic chemistry class, and they're your organic chemistry bestie, and you go to them for certain things. And then there's someone else who's really good at navigating how to manage school life and working in different clubs. And then you have another friend who might be good at, I don't know, your dating life or something. So you have all of these different people in your life who serve as your board of directors, and their one ultimate goal is to help you thrive. So I think the purpose of a mentor is to help you kind of thrive and figure out what's best for you. It may not be the same thing that they are going through, and also help you figure out kind of how to avoid the pitfalls that they've gone through. Because if I'm mentoring someone, I would hope that I could help encourage them to do better than I did, so that you can uplift the next realm.
Yeah, thank you for that. We have a question from Christopher in the chat. So they ask, what conditions are best diagnosed through telemedicine? What are the limits? And would you recommend patients physically come in for certain symptoms rather than meeting virtually first?
That's a great question. And it's very hot in the news. Telemedicine, I like to think of as a great adjunct to healthcare. I don't think it should be the only thing. There are a lot of things. I think that when you diagnose a disorder, as you've seen, like we didn't see this patient, but without the lab results coming back, I would say if I were seeing her, I would think she either had gonorrhea or chlamydia. I didn't, we need the labs to treat her and know which one, but like 75% of the visit is done before you go in the room. So if our medical assistant or nurse came to us and they were like, there's a 22-year-old girl, she says she has a new partner, she's had this discharge, it itches, it smells, whatever. And I say, okay, so let's get out that gonorrhea and chlamydia swab and wait to see what comes back. So we've already had that in before you even speak to them. And then you use that 25% of the physical exam to kind of confirm what your diagnosis is before you go in the room. And sometimes you don't even need that. So for instance, if someone came and they were saying, I have this chest discomfort, it happens every time after I eat something spicy or some oranges, and it gets better sometimes after I take a Tums, but it keeps going. When I went in, I would say, okay, you have GERD. I wouldn't have to touch you. Sometimes I'd be like, all right, let me give you your money's worth, listen to your heart and lungs. So I think that there are certain conditions that are best diagnosed through telemedicine. So the things where you don't necessarily need an exam. Now, if someone came in and they were having chest pain, or they had an ulcer on their foot or something like that, they need to be examined. So I would strongly recommend that when it's time for an exam, you need to go in. There are some patients who try to push the limits and they're like, oh, I'm having chest pain and I'm short of breath. Please go be seen. Or my stomach really hurts. It's a 10 out of 10. I can't move and I'm vomiting. You need an abdominal exam and vital signs. So it gets to that point of just figuring out where to set your limits and what is safe for a patient. And then honestly, with liability, like what could you defend in court as not sending in? So there is a limit. And I think that is one of the reasons why a lot of telemedicine companies do not hire physicians who don't have at least 5 years out of residency, because they want you to master that physical diagnosis and the history taking skills so you can do it in the absence of an actual exam. And there are some things you can examine online. So if someone had a rash, they could take a picture. If they had a swollen, sore throat or something, you could have them take a picture of it or video them and see how they walk, if their gait is off or stuff like that. So there are some things you can do, but there are definitely limits.
So I actually have a question regarding the images that you showed of the cervix. So I was wondering how that would change if the person was transgender.
Mhm. So if the person was trans, they have a lot of times when women who are trans have what they call bottom surgery, they get a neocervix or neovagina, and there are instruments that are used to dilate it. Um, and it doesn't necessarily make all of the, because it's not made with cervical mucosal tissue, it doesn't make a lot of the like discharge that a person who was born sex assigned at birth as a female would make. So there are differences. They could still have an infection, so you would still look, you can still swab, you'll probably still get the same results, but it would look different.
All right, well, I'll take like two more questions just to be respectful of your time.
Good question to end with. Um, I really love people. I love having conversations. I always thought that I would go into primary care. I wasn't exactly sure that it was necessarily family medicine, although I did join the family medicine interest group when I started med school my first year. But I wanted to go with an open mind because I think that when you guys get to medical school, it's always great to not necessarily have kind of a narrow view on what you think you'll go into, because I had a lot of friends like who would swore that they would want to be an OBGYN, and they had their OBGYN rotations at the end of the year and they were like, I don't want to do this. What am I going to do with my life? So it's always good to kind of go in each rotation and say, okay, this is 4 to 6 weeks. I can do it. I'm a surgeon this time, or I'm a GI doctor. So you can live and kind of go back to your checklist and say, okay, this is what I liked about it. This is what I didn't. But for me personally, I just love engaging and seeing the family from birth to death, being able to talk to a family and say, okay, I know without HIPAA and all of that kind of stuff, but knowing what's going on in the family, like, okay, she's stressed. I saw her mother last week and she told me that there was a fire or something like that. And just knowing and having that connectedness, as well as being able to, kind of just have that intimate relationship. I had an OBGYN preceptor when I was in medical school, and I went to clinic with her, and I loved her clinics because she had women, of course, all of her clinic, but she called it homegirl time. And every time before clinic, she would look at something on the news or a magazine cover or something and come in with the same question to each patient. So I might be dating myself by saying this, but I was on her rotation when Prince William and Kate got married. So every room we went in, we were like, okay, so what'd you think about that dress? And it was just so interesting to see like that connection that you build over time. So that's, I guess, why I like family medicine, is because of the social connection. You're welcome. It's also, one other thing is, it's also the most diverse field. As someone who likes a lot of different things, you could have so many different jobs with family medicine, and you gain so many different skills because you're kind of like a master of none. So, like I said, I worked at a federally qualified health center. Some of my friends work for health departments, some work for Planned Parenthood, some work for Kaiser. I work for a telemedicine company now, and that's a really good gift because medicine is changing, to be honest with you guys. And if you love it, go for it. I love medicine. But there's gonna be a big change over the next few years, and it's good to have that adaptability, because I've been noticing with a group of my friends, I think everybody's getting kind of like the 5-year itch or whatever you want to call it after residency, and wondering what's next and wanting to do a job change. And in the past, a lot of people they were like, okay, I'm gonna be a primary care doctor for 30 years. That's not happening. So it's good because you can kind of be a chameleon and figure out how to infiltrate different realms with your skills.
Yeah, thank you for that. So thank you so much for that insightful session, Dr. Derouen. I really enjoyed how interactive and encouraging you were, and I hope to have a session with you again in the future. If you
No
would like,
problem.
oh, thank you. If you'd like to post your social media handles or links to your business endeavors in your chat, please feel free to do so. I know you have a website, so if you'd like to link that for our students, I'll definitely post it in our chat as well. And to our WSU students, please make sure you complete the Google survey posted in the Zoom chat, summarizing this session to obtain your shadow hours. Thank you all, and I hope you have a great night.